Oh, yeah.
So if we're looking for these, how do we locate them?
That is a great question. So some of the programs, we don't have a list that exists. You all have, you have a little bit of one. Yeah, and so mostly it involves calling around and saying, do you offer this type of service and program? And so it's just knowing about them. Typically people, agencies that offer these programs advertise them quite readily because they're expensive programs that they have invested a lot of time and energy and effort into training their therapists on, so that they'll say we offer parent-child interaction therapy or triple P, positive parenting programs. So you have to look for those buzzwords.
Well, the problem in the school setting is I have 800 kids in 3 days.
Yeah.
And so I don't have time to do a lot of calling around. And also our families usually can't afford therapy, so they usually are looking for free therapy. So any that on other places where you got stuff, I would be.
Being in that position, actually not necessarily having insurance is probably to the family's advantage in this case because they have access to a few more. A lot of these services are provided through Medicaid, if they're on Medicaid. But that's exactly why we came up with Project Focus as well, was because people weren't knowing necessarily where to go for these programs. And unfortunately, right now, a lot of the knowledge of where these programs are lives with certain individuals, as opposed to kind of being more broadly disseminated out there. And that's something that I think we're looking at. There's several different task groups that are looking at trying to figure out ways to get the information out there. But what we found is that even telling people, this program's available, they do this in child welfare, where they'll say, you have total access to PCIT in the incredible years, this and that, people still don't call and utilize the service. They don't necessarily get how it's connected to solving the problems that they have. So we want to approach it from both ends, is increasing the availability of that knowledge, but then also simultaneously helping people realize this is why you would want to use this type of program, because just offering it and saying that it's there, people aren't really accessing the finding. Is that consistent? I see some nodding. You've seen that happen. So, for example, parent-child interaction therapy, you're sitting next to a couple of folks that do that at Harborview Sexual Assault and Trauma Center. Where else is PCIT kind of in the general area?
Odessa Brown.
Odessa Brown.
Sound Mental Health in Bellevue was going to be doing, I don't know if they have it up and going.
They're going to be getting started with that.
Yeah, actually, I think you can say strongly enough how fortunate low-income families on who have Medicaid are with being able to receive evidence-based treatment. I think it's probably easier for those individuals to get treatment than it is for people who are on private insurance.
I think that's probably true.
Okay, unique to Washington State.
That could be unique to Washington State, but yeah, it's. And for some of these programs, like these ones I'm going to talk about for the older kids, I have to blast through this, functional family therapy and multi-systemic therapy, sometimes you can only access these types of programs through certain systems. For example, getting multi-systemic therapy, you have to be involved in the juvenile justice system. To get functional family therapy, a lot of times you have to either be involved in juvenile justice or the child welfare system to have access to these types of programs. So the access issue is a huge one, and one that we really want to be kind of thinking through, I think, as a cohort of people who are invested in linking kids up to these types of services. In the spirit of time, I'm just going to, because I think we have lectures on some of these that are coming up, I'm also just going to mention, I'm actually going to mention just this last one, Match ABC. This is a fairly new program, and it also is similar to CBT Plus, which is being, there's a lot of trainings that are going on right now too. And these are for kids that have internalizing and externalizing problems, so anxiety, depression, and conduct. And they're more modularized programs. These are new. They're on the cusp. Like basically what they've taken is the essential elements of different evidence-based practices that are out there in the literature and come up with modules and then put them together in this new format. And the research on it is really promising at this point, but it hasn't quite gotten to the point where we would advocate it as certainly like an evidence-based approach in and of itself, but it's definitely on its way there, and it's pretty exciting because this would be something that would be more available in the public domain, as opposed to needing to go and get specialized training in particular programs.
What's the age range for match?
For MATCH, it's at 4 to 14 about. And the 4 to 8 is really the conduct piece of it. You know, so you wouldn't, for the depression and anxiety, you're looking at kids that are more in the like 8-year-old range because they do a lot more cognitive work with those kids. So we've trained some cohorts of practitioners in Everett and in Aberdeen and pretty much those two areas in MATCH. And then more widely this CBT Plus, which is, and we're the whole state, people are getting trained in this, which is a close cousin to the MATCH ABC. For internalizing behavior problems, with Tyler clinging desperately to his mom, Mrs. Jacobs pulled out the separation anxiety back. So that's one option. But the other options that we have here, again, for kids with internalizing problems, we're really starting to make that connection more the cognitive behavioral therapy work. So what's the relationship between the fact that you have a certain thought, you know, I'm no good at this, that impacts how you feel about your efficacy and your ability to perform at school, that kind of thing. We kind of help kids learn that there's that link between those thoughts and feelings and behaviors, and what I do can further impact that, or if I, you know, go and do something fun, I can actually elevate my mood that way. And then especially for kids that are depressed or maybe have post-traumatic stress about something, really trying to get them to do something that either face their fears or become behaviorally activated in some way. Typically in this role, the caregiver is involved more as a coach as opposed to the therapist, right? So with externalizing, whereas you're teaching the parents to be the ones that are kind of interacting differently with their children on a day-to-day basis, for this it's more the child's learning a set of skills and strategies with you, and then the parent is helping to reinforce that at home or remind them to use those skills and strategies. So the caregiver involvement is still critical and important, and one that I think a lot of times doesn't happen as much that we've seen clinically. But it's not, it's a different take on the parent role as with the externalizers. So I love this cartoon because it just says, talk about negative thinking. Watson's thought bubble has slowly turned into a black cloud. We talk with kids about double bubbles, right? You know, and sort of, okay, what you just had was a blue thought or, you know, a down thought. You know, what's more of a true thought? What's something that's a little more accurate? Because we worry I think the kids walk around with little black thought bubbles all the time. I can't not mention medication with the internalizing. A lot of times we actually get kids that are medicated for externalizing behavior problems as well. I should mention that there's not a lot of literature that shows that medicating kids for externalizing behaviors does much. Sometimes it kind of dopes kids up a little bit so that they don't behave as much at all. But that's not really, and we don't really think that that's an effective approach because we're not really teaching kids what to do in those types of circumstances. For depression and anxiety, it's a little less clear because there are some really effective medications that are fairly safe for kids to be on. But we get really worried because a lot of times we see kids that are on multiple medications. Medication alone would never be indicated. And sometimes we see kids that are just being managed only on medications without receiving any benefit of some psychotherapy. And so you just want to keep an eye out for that. Antidepressants are okay. Other things that we see kids coming in on, mood stabilizers, atypical antipsychotics, really there's not as much. That's a much more higher risk, lower gain kind of thing for internalizing behavior problems, but you'll see it. You see it a lot, unfortunately. There's less programs that are available for internalizing behavior problems in Washington State too. So they match ABC, as I already mentioned. Interpersonal therapy for adolescents. I don't know, for some of you school-based folks, there's some school-based programming that's done around the depression, like MAP, but it's not being very widely disseminated right now. So more you just want to keep in mind the core principles of the treatment and make sure, like, you're making a referral to a child that for irrational, unhelpful thoughts, teaching coping skills, how to calm down. You have to, if the child has a fear, you cannot very easily treat a fear without having them face the fear. But usually what happens when we have children face fears? How do children feel about that usually?
Anxiety goes up.
Their anxiety goes up. And so as a therapist, it's not, we're here, we want to make kids feel better, right? We don't want to, and so kind of this idea that you have to have kids face their fears and you actually have to make things worse a little bit before it gets better can be a real challenge for some folks, but it's really important and it's key for treatment. So, for example, if you have separation anxiety, you're kind of teaching them that nothing bad will happen if they're away from their caregiver. You're coaching them to have brief periods of time, away from their caregiver, and then it'll get longer and longer. And then again, the caregiver treatment focuses on reinforcing skills that are taught to the child, supervising homework tasks. The child, if they're germ-phobic, they might have a homework task of going home and like touching a doorknob or something. The parent would need to remind them and coach them to do that because most kids are going to avoid, right, and not want to do it. So you need to have someone to kind of coach them through that. And then for post-traumatic stress, you're looking at changing irrational thoughts. I'm still in danger, even though the danger's past, or it was all my fault, to something that's that's more realistic. You're looking at relaxation, teaching children how to calm down. But eventually, you're having them face their fear, not necessarily putting them back in the risky situation that they were in, they're facing the memories of their fears, right? So remembering on purpose in a safe environment and saying that it's okay. And again, from the caregiver, we really want them to be reinforcing this new thinking, supporting use of skills to cope with anxieties and stressors. Questions about that? So for anxiety and PTSD, again, we have MATCH, ABC, which I already mentioned. But then what we have that Shannon's going to talk about next month is trauma-focused cognitive behavioral therapy. I bet most people have heard of that. Yeah, this is sort of kind of a trendy, is that the right word to use? It's trendy because it works really, really well. It's a very effective strategy for working with kids that have some trauma exposure. It's youth-focused, but the caregivers also to be involved. A lot of times we've been seeing clinically as well that therapists tend to work a lot more with youth and have a little more challenge bringing the caregiver in, but we really think that that's an important component with that. So like half the session with the youth, with the caregiver. And then, how many of y'all went to the talk last time on wraparound, the Arcade? A handful of y'all did. I also just wanted to mention there's other programs that are out there, wraparound. Who's heard of wraparound? More people have heard of it. Okay, so this isn't an evidence-based practice program per se. It's a process, and so it's a way of kind of getting children access to services. It doesn't necessarily have it. Usually, what we kind of advocate for anybody who's in the wraparound is that they would be any child that has internalizing, externalizing, attention-related problems. You would insert active therapy into whatever it is that they're getting. That's part of this kind of bigger wraparound piece. But it can be really helpful. A lot of the kids that we work with tend to have a lot of people involved in their lives, right? And so this helps coordinate those folks and gets everybody on the same page. But we always say, too, just watch out for more is not necessarily better. In fact, there's some research that's out there that says that when you overwhelm parents or caregivers with a whole lot of different therapy things that they have to do and other activities, that it actually doesn't work to anybody's benefit. Kind of that one thing at a time works a lot better.